Thanks very much, Nikki. So I'm Mark and I'm in Glasgow. This project is Project 61, but my master's project was actually Project 1. So the NILS has been very important for my research career generally. So thank you to everyone in this room. Really, it's been good fun. So just to kind of pick up a bit on what Dermot was saying, this project kind of straddles the mortality study and also the NILS itself, the 28% sample and the 100% sample. So it just shows what you can do with this population fraction compared to England, Wales or Scotland. You have similar data sets. First of all, I'll start by first of all thanking everyone in the NILS and also thanking the partners for this project. Whenever the idea for this project came about, I went down to speak to Contact NI, and they were really, that was before I started writing the project up. They were very, very, they were really essential in kind of formulating what the research was about. At the time, there was a big academic debate about the importance of diagnostic criteria relating to mental health following bereavement. But in terms of the practical elements, those weren't the questions that were really important to people on the ground. So they really kind of structured the direction the research went and the questions that we answered. And so they really were very important for this whole research project. So just to run through the kind of research questions that we laid out, this project was funded by the Economic and Social Research Council. So these are the four kind of big hitters that we went to get the funding for, along with the sub-questions that we answered for our stakeholder partners. So first of all, does bereavement lead to an increased risk of poor mental health as measured by antidepressant medication? So this is kind of a coarse measure, but it does give us good information about mental health at the population level. Next, how does the likelihood of poor mental health vary according to cause of death? So we know within Northern Ireland there was a big discussion of increased suicide rates. So again, looking at mortality and how does suicide and these mortality outcomes affect the people left behind. Then looking into the detail, how do characteristics of individuals, how do they interact with these bereavement circumstances and mental health? And then finally, the kind of interaction of the two. So do characteristics of individuals differentially mean that they're predisposed to better or worse mental health following bereavement? Just a bit of a discussion about what the NILS can really do. What other ways could you answer research questions like this? Maybe you could use questionnaires or do face-to-face interviews. And thinking into this, that's with people who are recently bereaved. If we want to look at variation by cause of death, you'd have to go and use this as part of the survey. And then how would you actually find details of these people? Would you be looking through and knocking the door after the suicide takes place? Or just ask, hand out a survey to everyone? It'd be very difficult to do this statistically. It'd be very difficult to do this analysis, but the data here means that we're able to answer these kind of questions in a way that has minimal respondent burden. Now, of course, it's really only the tip of the iceberg. It's not gotten any detail about the circumstances of death or about their experience of poor mental health. But by understanding at the full population level, the tip of this iceberg, then the rest of the picture, that's what the Contact NI, Cruise Bereavement Care, they can really look into the details here. So it's feeding information that frontline workers can really use. So looking at the structure of the data, this project started off in 2001. So we have in NILS members, 28% of the NI population, from birth to death, age 0 up to 110 or whatever. So we have a good representative sample of the population there. We have information on the co-residents. So from that we can see the children, the parents, the spouses in households. And from the Northern Ireland mortality study, because we have 100% linkage, we can see for all of this 28% sample, we can look at their experience of death in the household. So again, this 100% linkage means that this project is possible. Land and Property Services gives us information that John was talking about affluence and deprivation. And then we also have other information, as Dermot was mentioning, about the broader structure, so we can account for all of those in terms of the analysis. Aidan's going to talk a bit about the electronic prescribing database. So we have information from 2001 through to 2007 about deaths for the whole population. And then for these NILS members, we see their use of prescriptions. So that gives us both the bereavement circumstances for the NILS members and then their mental health outcomes. Then I'm presenting here just the overall results, but we have accounted for variation in affluence, variation in neighbourhoods, and urban-rural variations. Excuse me. Okay, so overall, for this project, it came down to about 320,000 individuals, again, fully representative of the population. About 7% of that cohort experienced bereavement due to illness over that 8-year period from 2001. And about 850 experienced bereavement due to sudden death, so that's either a road traffic accident or a violent death. And then 611 experienced the bereavement of a close family member through suicide. So that's the overall kind of context, and that's the structure for the individuals. This was the first project that got the linkage of a practice identifier. So from the prescription information, we were able to look at GP practices. So I think procedurally, in terms of getting the agreements for that, there was quite a bit of work behind the scenes. Technically, it was just a string of numbers. It was a very, it's a tiny bit of actual data that's transferred. But in terms of the contextual information that it gives us, from this we were able to see that about 6% of the family practitioners were seeing, they were providing support to somebody who was bereaved due to suicide basically every year or every other year. By comparison, 27% in this time period didn't experience, weren't providing support at all to people bereaved due to suicide. So again, in terms of GPs learning their skill through practice, for a large proportion, it's such a rare event that broader information and information training support for what to do in those circumstances is really key. And so the bereavement coordinators can really play a great role here. Just to very quickly talk about affluence. So this is the deprivation deciles. Each block here represents 10% of the population. So for no death, we see basically 10% in each category. For those bereaved due to illness, you can see the top 10%, the most affluent 10%, experience less bereavement. And then if we shift over to suicide, you can see suicide definitely affects deprived communities much more often. So the top 20%, the richest 20% of the population experienced about 10% of the suicides, whereas the lowest 10%, the poorest 10% of the population experienced nearly 15% of the suicides. There's a definite strong social patterning here. Looking at the mental health outcomes, so we'll start with again, it was based on the Institute of Childcare research. We looked across the age spectrum for a lot of this research. Looking at the working age population to begin with, about 11% of the population overall is using an antidepressant or anxiolytic medication. Then we can see a real strong dose response effect with the circumstances of bereavement. Bereaved due to illness, about 13%, then following sudden death or suicide, very greatly increased risk, so about an 80% increased risk of poor mental health following bereavement due to suicide, after accounting for the differences due to affluence and deprivation. At the younger age, it's not quite as pronounced, but there's a lower overall rate of antidepressant use, but it's still within sudden death and suicide, there's almost a doubling in the risk of a poor outcome. And the same appears at older ages. So again, about 11.7% up to 21%, so a huge overall mental health burden. So this is the scale within Northern Ireland. There's a doubling risk across these age categories. And thinking about the other questions, so what about the characteristics of the individuals? Dermot mentioned there about informal care and the stress that an informal caring role provides. So thinking again across the age spectrum, on the one hand you've got young carers. For young carers, providing informal care, it appears to be a caring burden that in itself provides a burden in mental health that is actually equal to the burden of loss of someone. So bereaved informal carers and current informal carers at a young age both experience very poor mental health. By comparison, at older ages, the caring, providing informal care is more of a providing a caring role rather than the burden. So in this case, bereavement after providing informal care, both the loss of the detriment due to the loss of the individual and also the loss of the caring role. So there's a double mental health disadvantage there. And then within the working age population, it falls in between. We don't have this relief from the caring burden that we see at younger ages. So in terms of both support for carers and support for bereaved carers, there's definite need to focus on the circumstances of the carers post their caring role. Then I think, I'm not sure if Aidan's going to talk about this, but we looked at educational attainment, so relating to this idea of sort of stoicism, the idea of the ability to rationalise pain and loss is good for your mental health. There seemed to be some sign of this, so people with higher levels of education, better mental health, above and beyond that could be explained due to affluence. And so there was this protective effect of education under some circumstances of bereavement, i.e. illness or sudden death, but in cases of suicidal bereavement, there seems to be no extra benefit of having a higher level of education. So this could have something to do with the ability to rationalise loss and more difficult processes. So in terms of the kind of grief work that frontline workers provide, standard models may not operate in the same way when considering people who are bereaved due to suicide. Now there is more information, so I would encourage you to look at the grief study. I started off by saying how important the stakeholders were for this, but in particular Carol and Anne, who are the bereavement coordinators for two of the trusts, they came in and spent some time with us talking through what the kind of services that they provide and kind of reflecting on the results of this study. And they've really been keen, supporting the flow of information throughout the health service about the work of these findings and also the future studies that the likes of John and Aidan and Dermot are continuing to work on here. Right, thanks very much for listening.